Hi, a great pleasure to talk about CERTAN, which stands for a checklist for early recognition and treatment of acute illness and injury. CERTAN is a structured approach to critically ill and injured patients that we have developed at the Mayo Clinic over the past decade with the goal of improving outcomes of critically ill and injured patients. So as a first step is why. As you can see here, key priorities identified by US National Academy of Medicine for clinical medicine is therapeutic harm, diagnostic error, and dying without dignity. All three being exponentially more important in the setting of critical care medicine. COVID-19 pandemics reiterated the problem by showing here in an international study that we have done with the Society of Critical Care Medicine, that for the same illness, COVID-19, the mortality varies across different hospitals from less than 20% to over 80%, just depending where you treated, unexplained by severity of illness and treatment availability. When you look for the modifiable outcome determinants when the patient is critically ill, most are not modifiable, like physiology, how sick the patient was at the time of ICU admission, demographics and comorbidities, or socio-economic status. What is modifiable is hospital strain, hospital quality, and to a small extent available specific treatments. Hospital strain means staffing, the number of nurses that are capable of treating critically ill patients. And then hospital quality is what we will talk the rest of this talk. How do you make processes accurate that you minimize diagnostic error, therapeutic harm, and dying without dignity? There is a challenge of information overload throughout medicine and particularly in critical care medicine. It is essential to extract and prioritize relevant data from the sea of data which are less relevant to what the patient is. When you look at an engineering way at, let's say, some medical process, like sepsis resuscitation that takes 25 steps, and each step is done the best human can do, which is 95% accurate, the chances that all 25 steps will be done perfectly well is only 1 in 3. That's exactly what we get when we measure it, even at the best institutions. So to improve the probability of success, you have to either cut down on unnecessary steps, so focus only on relevant and prioritize it, and do those things that are important better than humans can do, more reliably. If you need it to be automated or double checking or standardize the process so it can be above and beyond what we naturally are able to do. It is also important to put critical care medicine in a context of overall industrialized healthcare across the world now, with its hurry, blur, cruelty, and burden to the patients, and contrasted with the goal of patient-centered care with its elegance, high-definition responsiveness, and being minimally disruptive. Our colleague from Mayo Clinic, Dr. Montori, runs the organization Patient Revolution with some of the clinicians, patients, and leaders around the world to advocate for minimally disruptive medicine as a way for caring for patients that minimizes the disruption healthcare causes in people's lives by reducing the burden of treatment if not necessary. When you talk about critical illness, it's very important to understand that critical illness comes in the context of life, close to the birth. You are close to it's a vulnerable period and close to the other extreme of age at the very elderly. Some of us may have chronic illnesses that keep us walking close to the cliff, or certain behaviors or bad luck can get us to experience the need for critical care. As you can see here, the critical care is trying to get you back to life with palliative care, rehabilitation, and other things, or to provide the cushion for the last fall if the condition, which is severe and irreversible. In any case, the metrics are not just alive or dead, but it's quality of life, quality of dying, and quality of relationships. So, certain is a standardized, simplified approach to evaluation and treatment of acutely ill patients, with a vision to maximize quality of life in critically ill patients and the mission to implement certain diverse environments around the world to minimize preventable death and disability. The critical elements of critical care are depicted here. First, stabilization with coordinated early diagnosis and aggressive resuscitation. Then rounding, shared mental model and system-based plan within the interprofessional critical care team. And it has to be patient-centered, where the needs of the patient and family come first. In a study across 12 countries and 35 ICUs, certain was shown to improve many of the evidence-based processes of care, decrease ICU and hospital and 28-day mortality, and reduce length of stay. When applied over longer period as a longitudinal coaching program, it also led to sustained improvement and lower costs of critical care. After the study, we extended the certain program into a flexible learning and coaching platform consisting of online modules, on-demand webinars and multiple choice assessment, virtual simulation sessions, workshops with remote simulation and competency assessment, and certain coaching, the 40-week or 1-year-long longitudinal remote video coaching focused on case discussions, quality improvement, and curriculum topic updates. This is the interface for the virtual simulation, where we and the clinicians from really around the world now work the patient scenarios according to the certain approach principles to minimize errors and increase the chance for the best possible outcome. Certain is rapidly adapted to different things. We've used it in New York City during the overwhelming COVID-19 pandemics as a support for COVID-19 in the Balkans and in the ICU, Society of Critical Care Medicine Stop Virus collaboration. During the war in Ukraine, in support of anesthesiologists faced with a critical care trauma during the war. Here is the depiction of the certain approach on one slide. This is literally everything we ever do to improve critical care process and outcomes of our sickest patients, starting with the need for CPR. If that's not needed, immediate threats of life, according to the ABCDE acronym. Procedural checklist for urgent interventions, focused history with allergies, medications, past history, and social history, bedside test, including the critical care ultrasound and a point of care labs, formal differential diagnosis, shared mental model, focusing on organ system-based plan, and understanding the patient as a person with its preferences, psychological and social and spiritual needs, with what we call a get to know me board. So step one is a primary survey addressing immediate threats to life. So if the patient is unconscious and apneic or gasping, you don't check the pulse, you proceed with the CPR. If that's not the case, you try to identify immediate threats to life, working through the airway, breathing, circulation, visibility or neurostatus, and exposure. You immediately obtain IV or, if needed, intraosseal access, very important in emergencies. Respiratory and hemodynamic support, immediate with oxygen, non-invasive or invasive ventilation, and vasopressors. And point-of-care ultrasound, point-of-care laboratory test for the things that you cannot glance from physical exams, such as potassium, calcium, lactate, arterial blood gas, and coags. Additional information is obtained with a very focused history of pertinent medications, allergies, and past history. This is a little video of a critical care ultrasound as the stethoscope, where we approach it, as you can see, in about 2 minutes, looking at the anterior lungs.
Change the menu. Presets deep. And this time I'm going to go abdominal.
Changing the probe with the same gel to evaluate the kidney.
In fact, abdominal is better in terms of kidney and
Diafragma, tečnosti u abdomenu i tečnosti u plućima.
Okay, then I will change it to cardiac.
Finishing with a cardiac exam, starting with a subxiphoid view, including the volume assessment with evaluation of inferior vena cava, and 3 other heart views: parasternal long, parasternal short, and the 4-chamber view. As you can see here, the whole exam is done with less than 2 minutes, supplementing the physical exam with ultrasound as a stethoscope. In step 2, you move with a system-based assessment and plan, making sure that you do not forget or miss essential parts in each system, including sedation, delirium prevention and treatment, pain treatment, cardiovascular medications, lung protective ventilation, fluid balance and electrolytes, glucose control and prophylaxis, nutrition, venous thrombosis prophylaxis, antimicrobials, skin integrity, wounds, medications, devices, and catheters. Physical therapy may need to be done even on day 1. Family presence, goals of care discussion, social status, and the reason or safety for ICU discharge. You then move to formal differential diagnosis according to the presenting complaint, like the respiratory distress. In this case, you first start with the interventions regardless of the cause, excluding the key emergencies: tension, pneumothorax, usually with the ultrasound, airway obstruction, and anaphylaxis, shock, asthma, COPD, pulmonary embolism, all the way down to pneumonia, sepsis, ARDS. Finally, before you move out of the room, you make sure that you pay attention to humanizing critical care. When the critical care developed initially after the polio epidemic, as you can see here, medical students in Copenhagen were ventilating manually children who were affected by polio. Within 3 months after that pandemic, the first commercial ventilators were developed, and then within a year, the first intensive care units to provide life support developed in both North America and in Europe. Even at that time, as you can see here, this medical student is reading the picture book to the child while ventilating her. It is important to understand that critical care success is not measured just by statistics of survival, but by the quality of lives preserved or restored, by the quality of the dying of those whose interest it is to die, and by the quality of human relationships involved in each death. As you can see here, this is a Get to Know Me board, one of the tools we fill out on every patient to bring them from anonymity. And I'll show you an example at the end of the talk. So let's move to see how we apply certain in clinical practice. So you're on call in the intensive care unit, and there is a code 45 or code blue for syncope. There is emergency in one of the hospital wards where the patient passed out with a brief clonic tonic seizure. When you come there with a nurse, this is a 60-year-old man with cerebral palsy who had colectomy 2 weeks ago for ulcerous colitis and has had persistent ileus and was on parenteral nutrition for that. On your primary survey, he protects the airway. He has mildly increased work of breathing, and oxygen saturation is 85% on a non-rebreather, 100% oxygen. His knees are mottled, his systolic blood pressure is only 60, and his heart rate is 145. It looks either sinus or flutter, you cannot tell on a monitor. On disability, his response to voice, he mumbles, he has some stiffness, probably from his cerebral palsy, but there is no focal deficit that you can see on cranial nerves. He does have abdominal distension, but no peritoneal signs. His ultrasound shows no B lines, no tamponade, some hyperdynamic LV, left ventricle, and enlarged RV with some small free abdominal fluid. His lactate is at point of K, it's 11. The rest of the labs are relatively normal, except the white cell count this morning that was 18. Hemoglobin is normal. On the ECG, you can see here that the patient has sinus tachycardia and what looks like a right bundle branch block, some non-specific ST changes in lateral leads. This is the surgical admission, so we don't have the baseline ECG, so we don't know if this is new or old right bundle. The X-ray shows the central line that the patient has had for the CPN, and relatively normal size of the heart and no significant infiltrates on the lung fields that would explain severe hypoxemia. We talked about the ultrasound. As you can see here, in this right parasternal view, along parasternal axis, that LV is functioning normally, while the RV is dilated. In a short axis, again, this is at the mitral valve level. The left ventricle is relatively preserved, but the right ventricle looks very, very dilated. We don't know if it is new or old. He's now up in the intensive care unit. He's barely stable with a oxygen saturation of 90%, respiratory rate of 30, heart rate of 130s, and blood pressure of only 95/55, despite norepinephrine at 0.5 micrograms per kilogram per minute, vasopressin at 0.08 micrograms per kilogram per minute, and epinephrine of 0.1 micrograms per kilogram per minute. He's on high flow nasal cannula oxygen with 100% at 50 liters, saturating only 90%, and he started on both empiric antibiotics and IV heparin for possible pulmonary embolism. In differential diagnosis, so we think he is shock. He got a half a liter of normal saline, but we stopped it because of this dilated LV, and we started norepinephrine. Nothing to point out for anaphylaxis. He may have sepsis from abdominal source, and we have started antibiotics and getting the surgeons at the bedside. No signs of bleeding, acute abdomen. He doesn't have peritoneal signs, but it is post-surgical abdomen, so it is possible that there is infection. No bradyarrhythmia, this is sinus, nothing to point to coronary syndrome. Pulmonary embolism is high on the list, although the patient was on prophylactic heparin after surgery, but that sometimes fails. Nothing to suggest dissection or tamponade. On a plan by systems, the next step, we are monitoring. At this point, he doesn't need sedation or pain management. With cardiovascular, we're titrating norepinephrine, epinephrine, and vasopressin. Someone is thinking, should we start angiotensin II, even inhaled nitric oxide to decrease the RV afterload? If you are to think of ECMO, VA ECMO, you're probably going to call the ECMO team now because it takes an hour or more to set up the ECMO circuit and cannulas. Do you want to try advanced monitoring with Swan-Ganz catheter and maybe small RV fluid bolus? Probably unlikely to help. Moving to the respiratory system, he's on high flow oxygen. You're considering maybe CPAP of 5, so you could deliver inhaled nitric oxide, and you are worried about the risk versus benefit of intubation in this patient. With regards to kidneys, he needs urinary catheter to monitor urine output. We're aiming for even fluid balance. We always try to avoid nephrotoxins, and we are monitoring electrolytes and pH, which currently are okay. He cannot have anything by mouth in a case of intubation. We are monitoring glucose, and he was started on stress steroids because of shock and high dose vasopressors. We started IV heparin, and we are considering giving the thrombolytic, TPA. Should we do full or a half dose given the recent surgery? We don't yet know. We reviewed the antimicrobials. We started vancomycin and cefepime and metronidazole, and we will de-escalate according to the cultures and course. The wound looks okay. Surgeon is at the bedside, and they want to do the CAT scan. They also worried to start thrombolytic if the patient is to go for a surgical intervention for presumed anastomotic leak. We discussed the doses and indications with the pharmacist, and we reviewed the devices. He needs the urinary catheter, central line, and arterial catheter, and he needs a strict bed rest. His wife is at the bedside, and she confirms the full code, and we are worried how can we safely transport him to the CAT scan to confirm or exclude pulmonary embolism. And then this is a question we posed to our residents, and as a next step prior to the CT chest and abdomen that surgeons would like before TPA or to exclude the leak, you consider the following: to intubate with a ketamine sedation, with propofol sedation, to fill out get to know me board or something else. There is a misconception that it is true that propofol is worse hemodynamically, that ketamine would prevent severe hemodynamic collapse in a patient like this, but in a case of severe shock, high dose vasopressors, and potential for cardiogenic component or RV failure, even switch to positive pressure breathing without any sedation can cause cardiac arrest, and ketamine as well can contribute. So we were scared, and we looked at the get to know me board that the patient's wife filled. And then we noticed something on this board here in a book. Favorite book is IQ of 63, So What, by Ben Anderson, by the patient himself. And this has been published, and this is all with the patient consent that I'm sharing with you. And so that's a really unusual title. So we finally, for the first time, have this patient in front of us as a person, not just as a pulmonary embolism or ulcerous colitis or cerebral palsy or another medical term that we use to label our patients. So we sit at the edge of the bed and start, ask him a little bit about the, interesting, you have written a book with an interesting title. And he literally within a minute of us holding his hand and talking about that book, his heart rate and respiratory rate improved. And we also noticed that some of his mumbling is not from shock. He just has cerebral palsy, so he's more difficult to understand, but his brain is perfectly functional. He was just very scared. Behind cerebral palsy was really amazing human being. And as the heart rate and respiratory rate decreased, it was safe to proceed with a CAT scan with fellow's escort, avoiding potentially life-threatening intubation. The CAT scan showed massive pulmonary embolism. We started the half dose of TPA, and his shock resolved in 24 hours with no bleeding. We have learned quite amazing stories and read the patient book the same night. All of this you can find free online in this publication. I have hundreds of research papers, but this is one of my favorite where the patient is the senior author. Thank you very much for the opportunity to present certain to you.